Hey everyone, we're going to touch base on substance abuse and other addictive disorders now. So, this is the second half of Unit 9, and we started with some different terms. So, addiction, you cannot function without this substance. You're actively using it, you're pushing it, it's creating problems in your life. Intoxication's when you're high, when you're drunk, when you're under the influence. It's what we're feeling while we're using a substance. Tolerance, we need more and more and more to feel the same effect. Once upon a time, I used to drink one coffee. Now I have like coffee and an energy drink to get the same effect from the caffeine. My body has developed a tolerance. Withdrawal is what we feel when we stop using that substance. So, under the influence of caffeine, right, I have energy, I'm awake, I can move. Without that caffeine, it's generally opposite. I'm tired, I'm sluggish, I have headaches. The more we have been using the substance, the more severe those withdrawal symptoms tend to be. Oftentimes, withdrawal isn't dangerous, it's just uncomfortable, with the exception of alcohol. Alcohol, when we stop using that substance, when we stop drinking, that can kill you. It is our dangerous one. So, when we look at substance abuse, our symptoms fall into a few categories: impaired control, social impairment, risky use, physical effects, what we see while we're using them. So, on the left, that's that DSM function or DSM criteria of what we're seeing in our patients while they're using it under the influence. What tells us they have a disorder. Prescription drugs, we got our scheduled. Y'all should have gotten this in pharmacology. We got some risk factors. Genetic, alcohol, 40 to 60% of your risk comes from the inheritance. So if you have a family member with alcohol use disorder, you have especially first degree family member, 40 to 60% risk of developing an alcohol use disorder yourself. We do have neurotransmitters involved for most of all of our substances. Dopamine and GABA have been our two primary. Environmental, right? Chronic stressors. Chronic stressors have roots in socioeconomic factors. Poverty raises the risk of unfavorable living environments, lack of parental supervision. And it might not be that your parents are ignoring you, it might be they have to work 2 or 3 jobs. So you don't have someone there to provide that oversight. Lack of educational resources, impaired support systems, friends who are using. Those are all social, or a lot of our environmental risk factors. When we look at cultures, a lot of substance abuse creates a sense of community, right? We go out, we meet at the bar. Y'all know I grew up as a nurse in the Army. There's a lot of drinking, it's just accepted. However, some countries do view some of these substances as sins, to include alcohol, and there are some religions that also view it negatively. So it could be a good thing because your culture may say, no, don't use them. We have a few substances. We're not going to talk about all of these. We're going to highlight opiates and alcohol, and then we're going to quickly touch base on cannabis and inhalants because those are some things we probably haven't talked about before. So, opioid use disorder, we have cravings, and we're going to use more and more. We're going to be drug seeking out drugs. Our tolerance, we're going to need more and more. Impairment, we're not going to go to work. We're going to not watch our kids because of our substance abuse. And then maybe we're driving under the influence. So when we talk about opioid use disorder, someone who is intoxicated or under the influence, they're going to have slow motor movements or be tired, their speech, right, depression, they're not going to pay attention. Meiosis, that pupillary constriction, is a big one. Our opioid withdrawal is what we see when someone stops using those opiates. So someone's been using opiates and maybe they can't get any, maybe they make the decision to just become abstinent, and it's sometimes called like pill sickness or dope sickness. Diarrhea, nausea, vomiting, watery eyes, runny nose, they're yawning. It is a miserable, they're super sick. We do have some nursing interventions. We'll talk about them when we get to medications to kind of make it feel better, but a lot of it here is just trying to make them comfortable. Unlike alcohol, opioid withdrawal will not kill you. You're just going to feel miserable. Opioid overdose is when y'all are generally pretty good about. Opioids slow and decrease respirations. So this individual will be found unresponsive. Or maybe you're watching them and their respirations are slow, they're cold, they're tired, their heart rate decreases. The meiosis, that pinpoint pupils. Narcan is what we give to treat this. Priority is always going to be airway, breathing, circulation. We're going to put this patient in the recovery position, give them some Narcan, call 911 immediately, stay with them. just to kind of make sure what's going on. Narcan does have that very, very short half-life, and the amount of opioids tends to exceed the Narcan, so we do have to be prepared to give a second dose of Narcan. So what else do we do for these patients? We want to get them into therapy, individual behavioral therapy, cognitive therapy, family therapy, group therapy, AA. Well, for these individuals, NA, support groups. We have residential treatment, we have therapeutic communities, we have sober livings or halfway houses, all these places that we can do. We do have a few different medication options. So methadone and buprenorphine are two options that we can, one, give to our patients to help them detox. So while you're withdrawing, you're having those negative symptoms, I can go ahead and give you that methadone or buprenorphine, and it makes the detox not so bad. Buprenorphine, we can see in the bottom there, we do have to wait 12 to 24 hours. So if our patient's using heroin, I could probably get away with waiting 12 hours to give buprenorphine. If my patient's using fentanyl, I definitely want to wait 24 hours. Buprenorphine will send your patient into withdrawals faster if they're actively intoxicated. So for buprenorphine, we do have to wait until they are withdrawing. Both of these, we can also use one to decrease, to detox the patient, but then also in that maintenance phase, I have gotten you detoxed, you've withdrawn from the substance, and you can stay on that methadone and buprenorphine long term to kind of just help. It blocks the euphoric effects of opiates. You still get a little bit of a high, but it's not the same. Methadone does have some pretty serious side effects we do have to watch out for, just to kind of keep an eye on the patient. Both of these do have side effects. Some of these side effects of methadone that are listed right here are honestly extremely similar to opiates. Constipation is a big one, and we'll see that with methadone and buprenorphine. Another option, if we are talking about opioid abuse, is naltrexone or Vivitrol. It prevents relapse, it blocks the euphoric effect, it decreases cravings. It is in a daily pill or monthly injectable. Well, we got some serious side effects. They do tend to go away after a little bit. Upset stomach is the biggest one. It generally is pretty safe. I've used naltrexone and Vivitrol a lot with some of my patients when I worked in addiction. The big thing is if we're talking about naltrexone for opioid abuse, our patient has to be 10 days free from opiates before we start to give it. To buprenorphine, we have to be about 24 hours free from opiates. Naltrexone, we want to wait about 10 days. I very much think of naltrexone as like an oral Narcan. So we do just want to wait, especially if we're going to give that Vivitrol injectable version. So switching gears, alcohol is one we're generally familiar with. It is the most commonly used substance in America. It's a sedative, it is a depressant, though we tend to think it creates that feeling of euphoria. Um, every time you go to the doctor, if y'all go for your physical, we generally screen for alcohol, just because of how big of a problem it is. And oftentimes it's because we don't think we have a problem. So we have binge drinking too much alcohol too quickly. So in a weekend, you're going to go out on the weekend, you're going to party, and you're going to have like 10 drinks in a day. Oh, I'm hitting buttons. Heavy drinking, you're just drinking way too much all the time. So we're not necessarily going to talk or memorize those blood alcohol content. I have definitely seen patients who've lived who have had blood alcohol over 0.45. This is an okay guide for most people, but if we have someone who has chronic liver damage and they have been drinking heavy for a long time, their body can handle alcohol over that 0.45. Females, we get 1 drink a day. Males get 2 drinks, and it has to really do with body composition. Females have more water weight, and it's how the alcohol disperses in it. 7 drinks a week for female, 14 drinks a week for males. So same thing. Drinking more than that is a red flag. And it doesn't mean like, hey, you definitely have an alcohol use disorder, but it means like, hey, let's take a look at it. So again, this is that DSM criteria. It's very, very similar to that first slide. You're using more, you're having those withdrawals, you're having the crazy cravings, that risky use, you're drinking and driving, you're not going to work. That goes along with it. Another version of just what we see with each blood alcohol level. So after someone stops drinking, So, in that first few hours after that last drink, as the blood alcohol approaches zero, we start to see those tremors, those shakings of the hands. That's a classic sign, kind of where that like eye opener came from. You drink all night, you sleep, and then you have to have a drink first thing in the morning to stop that shaking. Agitation, nausea, vomiting, perceptual changes, dangerously high blood pressures and heart rates in these patients. So, what do? We want to start giving that Librium or Ativan right away because we don't want the symptoms to get worse. Again, when we talk about that delirium tremens at the bottom, we are trying to prevent that from happening because we don't want our patient to die. We want our patients to eat, drink, give them fluid, keep them comfortable. We're probably going to be giving a lot of Zofran, gabapentin, all sorts of different things just to kind of keep them comfortable. So that's in the first few hours, 8 to 10 hours, we can start to see some of that psychosis or start to slowly see the seizures. Seizures are really big starting in that 12 to 24-hour point. And again, I want to give you that Librium. I want to give you that Ativan. My providers always scheduled it. Regardless, every 4 hours you're getting Librium or Ativan because we just, and we honestly had very few patients, if any, had seizures because we stayed on top of that Librium and Ativan. That's why we give it. Seizures on their own are not necessarily dangerous, but these patients do have a risk of having that like status epilepticus where the seizures start and don't stop. Now, what is the big risk is in that first 72 hours, these patients have a list of what's called the delirium tremens. This is not tremors. It's completely different. The DT is a medical emergency. It is an autonomic instability, lack of blood flow to the brain, delirium, high hypertension, insomnia, hallucinations. These patients need to be in an ICU to detox. If you had a history of the delirium tremens and you were detoxing again, we would not accept you at all. You had to go. Like we would send you to an ICU for that first 3 days of your detox. And they would honestly do IV like Librium, where you would get like a drip to keep it in your system continuously because of how dangerous it is. Wernicke-Korsakoff syndrome, Wernicke-Korsakoff encephalopathy, we are very much going to think of this as an alcohol-induced like dementia. The Wernicke encephalopathy is a very short-term memory disturbance. It's acute, it's reversible. Wernicke-Korsakoff syndrome is chronic, and 20% of these patients will not recover. When we look at that pathophysiology, when you drink alcohol, your body does not absorb all the vitamins and nutrients. The alcohol disrupts it. Also, we tend to see malnutrition because in given the choosing between eating or drinking alcohol, these patients often are going to choose alcohol because if I eat and drink at the same time, I do not find myself getting as intoxicated. So any patient who comes in, both of our clinical sites do it. If you come in and you've been drinking, I'm just going to start giving you thiamine, along with quite a few other B vitamins and multivitamins. We're not even testing for the levels because we just know. If we have someone who has encephalopathy or syndrome, large doses of IV thiamine, sometimes a few times a day for a few weeks. Again, with that syndrome, we might not fully ever recover. I'm going to skip this video. So what are we doing for those patients? We're going to keep them comfortable, shower, right? Even like self-care. If you have been abusing substances, you might not have been taking the best care of yourself. Maybe your inpatient's been homeless, and just going and taking that shower can be huge. Food and drink, we would give these patients and meet them with like waters and Gatorades, different, hit me in buttons today, different versions of electrolytes to get them eating and drinking. Education is a big one. When we talk, and we'll have it in a few slides, so it's relapse. If we do have someone, you almost have to plan what happens when you go out to a restaurant, what happens if you go out with friends who drink. We have to look at their whole entire life because other individuals in their life may very well be drinking. Even when we talk about like risk factors, had a patient who had a history of alcohol abuse decades ago, went through treatment, got sober, maintained that sobriety and recovery, and then he was in a car accident and they gave him narcotics. And he wound up addicted to narcotics. So if you do tend to be addicted to one substance, you very much have to watch other substances. So if we have someone with a history of alcohol use and they wind up going to the dentist, or even someone who has a history of opioid abuse, like it's important to know if you have to have surgery, if something happens, we have to talk about it because you may want to stay away from those addictive substances in the future. I would not want to give someone a history with a history of alcohol abuse a stimulant for their ADHD because of it. Therapy support groups very much the same, individual, group, family. AA is amazing. We have other groups besides AA. Motivational interviewing is really just a form of communication. It takes therapeutic communication a step further in how we do and have these conversations. We do have some medications for alcohol use disorders. Disulfiram or Antabuse is the first one. It's an aversion therapy. So if you take the Antabuse and then you drink alcohol, it makes you extremely sick, nausea, vomiting, headache, sweating, flushed skin, respiratory difficulties, confusion. It is important to know, and as a nurse, we do have to educate our patients on this. It is not just drinking alcohol. So, and that goes in two different ways. If I have a patient who is under the influence, if they come into the facility and they are drunk, I do not want to give them antabuse because it will make them sick. I have to wait that 12 hours until the alcohol is out of their system to start the antabuse. Now, if they're on antabuse, it is not just alcohol, aftershave, cough syrups, lotions, hand sanitizers. It could be if it's ingested, smelled, all of those that can make them ill. So they really have to look at what they're putting in and on their body and around their body if they're on antabuse. I never really saw antabuse used too much. I know other students, because I know y'all work, I love having y'all in class because we get to talk about what y'all have seen it used. But again, it's provider preference. My providers were not fans of antabuse. Naltrexone is the one we used frequently. Um, it is, again, we talked about this when we talked about opiates. It stops the cravings. It is an oral or a monthly injectable. If we're doing the mouth, either one, it can cause a little bit of upset stomach, nausea that tends to go away. We do want our patient to be opiate free for 10 days before we give the naltrexone. And I know we're talking about this with alcohol, but just because they're drinking does not mean they're not experimenting with other substances too. A lot of times you'll see more than one um, substance of choice. Acamprosate Camprol helps with relapse prevention. It decreases cravings. I really didn't see this used too much. It was used more on my patients who had severe liver damage. Naltrexone can be a little hepatotoxic. We know alcohol affects the liver. You have to take like 9 pills a day. It's like 3 pills 3 times a day. Um, so we do just got to keep out for it. Relapse prevention, we always have to look what's going on. If you know you've been sober and you've been doing good, but you're about to go home and you're about to visit family and your family drinks a lot and peer pressure, right? You have to plan for that. We have to look at other coping mechanisms. If we are using substances to cope, what new things can we do? And we definitely do always have to look at suicide risk because if you've been doing good and you've been maintaining your sobriety and something happens, right, that hopelessness, that failure, that impulsivity that goes along with substance use, these patients are at a high risk for suicide. So we definitely, kind of like in nursing, we start planning for discharge. On admission, we need to start planning for relapse on admission to an addiction, a substance use disorder facility so that there's a plan in place, one, to hopefully prevent relapse, but then also manage, right? We talked about in the lecture, it takes about 2 years for our neurotransmitters to restabilize after someone has been using. That's a long time to have these symptoms. So we very much have to work with these patients to try to see what's going on and to try to even it out. When we talk about the stages of change, this is how a patient makes decisions. We always want a patient to make the decision to come into treatment because they want to. If you are coming into treatment because your wife, mother, girlfriend, sister, husband, child, whoever is forcing you, you will not be engaged. You're less likely to be successful. So in pre-contemplation, the person does not realize I don't have a problem. In contemplation, maybe we're like, hey, I could be sick. There could be something going on. And that's where we use that motivational interviewing. We want to convince them, hey, maybe you need to change. The preparation, we're like, oh my gosh, I have a problem. I'm going to dump out all the alcohol in my house. I'm going to throw away all my energy drinks, right? If we're me, we're making these steps, right? I'm going to call an addiction facility. I'm going to go see my doctor and talk about it. That maintenance stage, we've gotten through that withdrawal, we've gotten through that detox, right? The substance is out of our system, and we are continuing. That's where we're giving, right, that naltrexone, maybe that buprenorphine or methadone long term. And we want to keep them from returning to that previous behaviors. We got some videos here. I'm just going to go back to the slides, not blank. Actually, we'll go back to quite a few slides. We had a few substances in the very beginning that we didn't really talk about when we talk about substances. We did talk about them in class, but I want to make sure y'all are aware they are in your textbook, so I'm not making this stuff up. Cannabis is the first one I'm going to touch on. Again, we're only really doing cannabis and inhalants. Cannabis has been in the news a lot. We're looking at the legalization of it. Legalization in some states, and they're looking at changing the schedule of cannabis. Y'all give me looks in class when we talk about it. Cannabis is a bad drug. We should not be using it. There's horrible side effects, decrease in IQ in adolescent use by 8 points. We see high rates of psychosis and schizophrenia nowadays. If we stop marijuana use in adolescents, especially boys, we would decrease schizophrenia in men by 30%. People are stabbing people because of cannabis-induced psychosis. And I know y'all will look at me because cannabis historically has been pretty safe, right? We have medicinal purposes. However, cannabis from 2024 is not the same as cannabis from 1969, right? 1969 was when Woodstock happened. Cannabis was like 1, 2, 3, 4% THC. Nowadays, we can get concentrated oils and dabs that are upwards of over 90% THC. So it definitely is different. When someone is under the influence of cannabis, we tend to think of our classic stoner. They're hanging out, they're tired, they're eating pizza all day long. It just, ugh, it is what it is. However, one of the things that we're seeing is that with the greater availability of cannabis in those states where it is legal, that we're seeing withdrawal from it. It's not just no more I used cannabis once and I'm fine. People are getting addicted. They're having to take it every day in larger amounts. And when they stop taking it, they're irritable, they're angry. We have aggression, anxiety, restlessness, and depression. I'm combining my words today. Insomnia, strange dreams, decreased appetites. So again, what we think of when someone is intoxicated with marijuana, the opposite tends to be withdrawal for marijuana. So please know it is a thing. I have had a patient admitted to our substance use disorder facility, and their only drug of choice was cannabis, and their insurance company still paid for them to be there because their addiction to it was so bad. The other one we're going to talk about are inhalants, because most people don't think about it. This is when we take volatile hydrocarbons, right? They're toxic gases, and we're inhaling them through the nose and the mouth, and they enter the bloodstream. Solvents, glues, adhesives, propellants, aerosol paint sprays, hairspray, shaving creams, paint thinners like whiteout, gasoline, propane, y'all, whipped cream. You go get your can of Ready Whip and you can get high. You have to be 21 to buy a can of Ready Whip in New York nowadays. Again, just like other substance, we do have some characteristics of someone who is using, right? They need to use more and more. They're not doing their major roles or having problems with their relationships. There is something, and this is where inhalants become dangerous because we think, well, it's a can of whipped cream, but there is something called sudden sniffing death syndrome. And particularly inhalants, butane, propane, someone sniffs it and you have a cardiac arrhythmia and you die pretty much immediately. We see this more so inhalant use, especially in those from 12 to 17, because it's very easy. Fearfulness, illusions, auditory visual hallucinations, distorted body image, apathy are very much what we see in someone under the use of our inhalants. Again, high doses, stupor, unconsciousness, amnesia, delirium, dementia, psychosis, coma, and then again, that sudden sniffing death syndrome. So we do have to be aware of all of those. I'm going to go ahead and end this here though, because we've talked about it all. Hope y'all have an awesome day.